Okay, so round three. Hello, everyone. Good afternoon. Hope you're all doing well and you're all enjoying the conference. My name is Rafa Ramos. I am one of the student liaisons for the Research and Education Committee. So I'm very glad that the conference is coming together the way it is. I'm also here representing the LMSA National Executive Committee because I am on their board as well. So I'm definitely happy for this intersectionality. So thank you for joining our track A1, Latinx, Gender, Sexual, and LGBTQ Identities track. And I am incredibly privileged to introduce our plenary speaker, Dr. Latanya Riddle-Jones. This is a big personal connection for me because I've had the privilege of learning under the instruction of Dr. Riddle-Jones during my pre-clerkship studies here at Wayne State University School of Medicine. Dr. Riddle-Jones is an engineering graduate from Michigan State University, and she received her medical degree from here at Wayne State School of Medicine, and then followed up by doing a pediatric internal medicine co-residency program at the Detroit Medical Center. She wears a lot of different hats, both within the school and within the city of Detroit. In particular, she currently serves as assistant professor at Wayne State University and as medical director for the Corktown Health Center, the first and currently, in my opinion, best medical home for Detroit's LGBTQ community. Her research is vast. She studies a range of topics, including the medical needs of the LGBTQ community, asthma, diabetes, and obesity. And over the course of her career, she has been incredibly awarded, including awards from Top Docs, the Trailblazer Award from the City of Detroit, and top internal medicine pediatrics faculty from Wayne State School of Medicine. If you have any questions, hold off to them until the end of the talk and just throw them on the chat, and we'll hopefully get to them in due time. We have a lot of ground to cover. So Dr. Riddle-Jones, thank you so much for being here. I leave the floor to you.
No, and thank you so much for inviting me. This is definitely a privilege to be included in this amazing conference. This is the most organized and fulfilling conference I've been to in years. So thank you, and hats off to all of the organizers. I have a lot to get through. We're just gonna touch the surface of all of what I would love to tell you all about today, but hopefully I'll move quickly because we don't have much time and there's so much more to get to in this conference today. But again, I'm Dr. Riddle-Jones, Latanya for purposes of today's talk. Please, you can address me by just using my first name. And objectives today, so I have no disclosures, as you all probably already know. I meant to put that slide in, but I forgot, so I apologize. But the objectives for today, just to discuss some best practices in preventative healthcare, including HIV prevention for all patients, especially focused on LGBTQ plus patients, evaluate the role of physician or provider in providing affirming and inclusive care to patients, and understanding the role of medical education in improving the care for LGBTQ patients in various settings, including that of Corktown Health Center. And so before we even talk about Corktown Health Center, I want to just kind of give you the origin story of Corktown Health Center really quickly. Corktown Health Center has a parent organization. The parent organization is HELP. That's the acronym for the organization. The organization is Health. I can't even think of it right now, I apologize, but Health Emergency Lifeline Programs. And so that organization is about 35 years old and started off as an ASO, an AIDS service organization in the city of Detroit. Now, that organization itself started off on the floors of Harper University Hospital, which is a part of the Detroit Medical Center, in the 80s during the AIDS epidemic. And so there were some people who were staff on the floor, and they noticed that the patients were sitting in their hospital rooms, just staring at the walls. And so this is when all the services in the hospital were a la carte, where the television service wasn't even included. Okay, so if you wanted to watch television in the hospital, you actually had to pay a la carte to have the television or cable services turned on. And so this is also before we had the medication AZT, which was also founded at Wayne State School of Medicine or Wayne State University. So patients were sitting in their rooms, looking at the walls and essentially dying of what we know now is definitely a disease that no one has to die of, which is HIV. And so the staff put together money and donations, and they turned on the television for every single patient on what was called the AIDS ward at the time. And so from that, they formed a nonprofit organization, which we now affectionately call HELP. And later, Ryan White Services, federal services came about. And there's a lot to talk about. We can have a whole lecture on Ryan White, federal services and what that means, but we'll talk about that another time, hopefully. But they became an AIDS service organization. And so they found that a lot of their patients got care for HIV that was federally funded. They were able to get care even if they were not residents of the communities that they lived in, and not even to mention citizens of the United States. But the Ryan White Care Act actually afforded medications, medical services, hospital cost for anyone with a diagnosis of HIV living in the United States. But the care that they received, especially if they identified as LGBT, was still not affirming and was still not inclusive. And so the board about 5-6 years ago decided that they wanted to do something about it. And thus we have the creation of Corktown Health Center, okay? So the mission, this is a part of our mission, but Corktown Health Center is Michigan's first health clinic dedicated to not only affirming LGBT patient healthcare, but also transforming the way that healthcare is taught and delivered, okay? And so that's where we get into some of the educational aspects of it and the teaching, okay? And so the services provided at Corktown Health, a vast array of services that we continue to add to. Some of those include preventative health services such as PrEP, pre-exposure prophylaxis to prevent HIV, PEP, which is post-exposure prophylaxis. So if anyone has had an occupational exposure or non-occupational exposure, we try to provide services and medication directed care for those patients. But we also have tobacco cessation, obesity treatment, prevention, medical care, health insurance navigation for those who have HIV and those who do not have HIV. We have a food bank, not literally a food bank, but we have services to get patients who are food insecure to more food security. And we try to look at long range services to help people to become more food secure. Okay. We have fitness activities that are live via Facebook, or patients can go to YouTube and watch videos of fitness classes that are available, which span various ability levels. Okay. Financial assistance for housing when it comes to the winter months, because we are in Michigan, and just various other services. One of the services that I'm very proud of is the fact that we have behavioral health services. Now, we are limited in those services. We have therapists who have social work training, but deliver various aspects of therapy. We do not have a psychiatrist on site, which is something that we're working on getting, but we do have a collaborative care model where we have a psychiatrist who does teleconferencing with the providers, okay? So we have 3 physicians. We have 2 primary care physicians. I'm the only one who's peds trained, so I'm internal medicine and pediatrics. I have an internist who's a new graduate who actually was a resident at Corktown. So we have the pipeline from residency, and we were able to hire someone who was a resident and did continuity clinic with us for several years. But we also have a geriatrician who works with us as well, Dr. Deol. I have 3 nurse practitioners who also work very independently in our clinic. But we have a conference once a week with a psychiatrist who's local, and she also has access to all of our EMR and our patients. And so we will sit down with the therapist and the social workers, and we will collaboratively talk about various patients and their cases and how we can do a better job of providing mental health care services to those patients. This actually came from a grant that we received through, who was the grant provider? I have to come back to you with the grant provider, but it was a national grant. And we did this collaboratively with Fenway Health, which is located in Boston and was one of the grandfathers of LGBT healthcare, and provides lots of training modules that are available online in collaboration with Harvard Medical School, okay? As well as aging services, which I told you we have a geriatrician who works with us, okay? So that's a little bit of our origin story, and these are some of the services that we provide. Now, medical education and training, how does that fit into this picture? We try to integrate education and training with everything that we do, okay? And so as Raphael was telling you, Raphael's earning not only a medical degree, but a PhD. And so has had various opportunities to have education at Wayne State. And so one of the big pillars of education at Wayne State is service learning, okay? We have various service learning opportunities at clinics across the state of Michigan, especially in Wayne County, which is where Detroit is centered, in Wayne County. But Corktown Health Center actually has lots of service learning opportunities when it comes to every service that we provide, whether it's preventative health care, where the preventive services will go out and provide HIV testing to any members of the community. And that testing is provided by training offered by Michigan Department of Health and Human Services via grants from the Centers for Disease Control, the CDC. Okay, so that's something that we are able to provide. We have students who come in and work with our food bank. They work with just every aspect of service that we provide at Corktown. But in addition to service learning, we have students who come in for continuity clinic and early clinical experiences, which start in the first year of medical school at Wayne State. And with me being a course director at Wayne State, in the preclinical years, I'm able to bring the students in preclinically, but I'm also involved in GME with the Med-Peds program, internal medicine, and the pediatric residency programs. So I try to do whatever I can with changes to the curriculum in the clinical years of the medical student education. And so we're always looking at ways to change the curriculum. And so the students have actually led an initiative to do a complete overhaul of the curriculum when it looks at DEI issues, inclusivity, and racialized medicine. And so we're really proud to actually be kicking off some of those new curricular changes when it comes to our cases that we're working on at the School of Medicine, when it comes to our standardized patients, just every aspect of what we're doing, because we really do need to jump forward in just doing a better job of taking care of all of our patients, okay? So GME, we have the internal medicine residents who do continuity clinic at Corktown. The Med-Peds residents have the opportunity to do so as well in their 3rd and 4th years. The pediatric residents have an opportunity to do aspects of their adolescent rotation in the community rotations at Corktown as well. And I actually give them some lectures. And then research electives, we also offer research elective options at Corktown because we're always doing clinical research at Corktown. We have nursing students who work with our nurse practitioners, but I also teach at the nursing school at Wayne State and at Michigan State. So they also can train under myself. We have pharmacy students who work with us in the preclinical years with some courses that we have at Wayne State, but also in the clinical settings when it comes to the Med-Peds and internal medicine residency programs and other allied health schools at Wayne State. We partner with various other universities because Corktown is actually an independent clinic and they actually purchase my time. I'm a Wayne State faculty member and practice group physician. So they purchase a portion of my FTE to be the medical director and to lead educational efforts at Corktown Health. So that's why we're able to have a relationship with various universities, okay? I'm going to try to go really quickly through other things in the presentation because I spent so much time there, and then we'll have some time for questions. But a lot of the residents will ask, and the medical students, you know, I'm a physician, why do I need to know about trans care or LGBT care? And so honestly, this is what I tell them. Your first duty as a physician, what do we tell you all? Is to do no harm, okay? So a patient will not disclose personal information such as gender identity if they're not comfortable with their provider. And for the providers on the call, the physicians on the call, you all know this. If a patient's not comfortable with you or they sense that you are discriminating, or if you've been the patient, you've been in a situation where you felt that from your provider, your nurse, your physician, you're not going to tell them everything about yourself, especially things that are personal, okay? And so not knowing a patient's gender identity can cause them to withhold information about medications, past medical history, social history, surgical history. I mean, key information that can ultimately cause harm, okay? Now, you can't tell a person's gender identity by looking at them. And there are so many people, including physicians, even surgeons, who still believe this. And so this is just completely false. All people, including patients, should be treated with dignity and respect, period. And I know everyone attending this conference already knows that, so I'm preaching to the choir, so I can skip past this one. And then you're not required to provide cross-sex hormone treatment. This is what I tell my students and my residents. You're not required to do anything that you don't believe you want to do, believe you need to do. But what you are required to do as a healthcare provider is to understand the treatment. Okay, you need to have a basic understanding of the treatment because you need to be able to take care of anyone who walks through your doors. Okay, and so once I just make it clear to them as the provider, as the students, usually all of the angst and the anxiety from the student or the physician they exhale. Okay, and they're willing to learn. Okay, and that's what we need. We need willingness to learn from our trainees and from our colleagues. Okay, and so the next thing, why should this be important to me? Okay, so being healthy is about more than just going to the doctor's office, and we all know that, and that's why we keep telling everyone about the social determinants of health, right? 80% of health outcomes or more, it's all about social determinants. And so we have to understand our patients and get as much information from them as possible. And that means that when a patient sees their healthcare provider, they need to be comfortable, and the provider should be knowledgeable because good health is multifactorial. Okay, so this is primarily what I'm trying to get through to the students and to my trainees. Frameworks of care. So this actually is from a Howard Brown presentation. So I was really excited to see Howard Brown represented today at the conference. But cultural humility and critical consciousness, these are frameworks that we know in medicine. Some of us are not as familiar with these things, but we need to be teaching them to our trainees and our students. So lifelong learning from patients, community members is so key. Continual self-reflection, awareness of biases and assumptions, awareness of dominant culture. Okay, so white, Western, cisgender, heterosexual, we need to be aware of it and how it plays a role in medicine. But, just be aware that medicine has been racialized. We have to be aware of that. Focus on others and conditions of injustice, and we have to put our knowledge into practice, okay? Another framework of care is trauma-informed care, recognizing that anyone may experience trauma, okay? And we need to recognize that when it comes to our patients, but not only our patients, with our colleagues, with our students, with those who are in leadership positions above us as well. Our goal is safety and to reduce re-traumatizing people. We need to have an awareness of power imbalances and prioritize the patient as the expert in their own care, their own life, in collaboration with the patient when it comes to taking care of themselves, establish trust and transparency. Okay, so when providing care, these are the things that I ask of my trainees and my colleagues. Understanding, so understand terms used, the diversity of identities. I want them to ask, if you're unsure of a term that a patient uses, ask them to clarify. We don't know everything, and you have to acknowledge that you don't know everything. We need to listen, and I've heard that several times today. We need to listen, okay? We need to avoid asking patients things out of curiosity. If your question doesn't have anything that is going to directly affect the patient's outcomes, their care, then why do you actually need to ask the question, okay? So ask smart questions. And once again, listen to experiences. So heteronormative and adjective is of or relating to the basis and attitudes that heterosexuality is the only normal or natural expression of sexuality. When I was a medical student, this was what I was taught, and thank goodness medical school education and curriculum is changing. There's on average 5 hours of education in medical schools across the country on LGBT health, but that is increasing by the day. Thank goodness, okay? But this is what I was taught. And so I just hope that we don't continue to teach in a heteronormative manner. And so the other thing I talk to my patients or my students about is the fact that, hey, when does the visit start, okay? It starts before you enter the room, all right? When a patient goes to your website, when they go to your social media, your radio, your TV ads, when they call the clinic, the pre-visit forms they fill out. If the form just has an area for gender that says female or male, you are leaving out so many people by not being inclusive on your forms. When the patient walks into the entrance or the waiting room, if all they see is cis representations, then you're making someone feel othered, okay? And then staff, when someone calls your office on the phone and a simple question can really just cause dysphoria, or make someone feel as if they're not important or they're not included. A question that we had on a form, or we had a patient asked was, it was assumed that the patient was feminine. And I think the person on the phone in another agency, now Corktown, said, okay, what is your husband's name? You cannot make assumptions, and you need to think about what you're saying to patients. And so right there, even though they were calling Dr. Riddle's office, the patient had a negative experience with Dr. Riddle, even though Dr. Riddle was not a part of the interaction, okay? So these are things that we all have to think about. Now, having affirming spaces and places. Advertising, like I said, needs to be inclusive and diverse. Staff, educated, diverse. Media needs to be affirming. Signs, symbols, magazines in the waiting rooms, forms, and check-in methods. And so at Corktown, we actually have those restaurant buzzers that go off. And so that way we can have someone come to the front desk without calling a name, without saying Mr., Mrs., or using any pronouns, okay? So these are just simple things. And like I said, we're just brushing the surface right now. All right, now when does your evaluation begin as a provider? Immediately. And for the providers on the call, you already know that. So phone calls to the office. You want to know about the interactions the patients are having with the staff, messages that are left. Sometimes we've heard some interesting messages, okay? Interactions with the staff. When you see clients or patients walking into the building or walking into the waiting room, your observation skills are at work at that time already, okay? And when we enter the room, we've started to look at the situation and look at who's in the room. And guess what? The patient is doing the same thing, okay? Same rules apply, and the patients have rights too. And so this is so key. And then sometimes the students and the residents will look at me and they seem to be shocked when I tell them the patients have rights too. And so that's just so funny to me when I have to remind even my colleagues that patients have rights and they can choose where they get their care and where they do not get their care, okay? And so patient introductions are very important, and invitations. And what I mean by that is when you introduce yourself to a patient, I introduce myself, I'll say, my name is Dr. Riddle, my pronouns are she and her. I will ask them, how should I address you? Which is very open. Not everyone needs to do that, but it just leaves the door wide open for a person to tell you how they want to identify, okay? Now, I know I wasn't taught that in medical school, and it may not be comfortable when you get started, but it's a way to go about doing it. The other thing is I have a lanyard that I wear, and my lanyard will have my pronouns. And so just having the lanyard with a pin that has your pronouns, you may not have to use your pronouns when you're introducing yourself, but people can look to see that you have pronouns and that you're aware of what pronouns are. And that right there may take a barrier down. Now, what do I mean by invitations? We as physicians are so used to feeling as if we are entitled to touch our patients, okay? And if you get nothing else from my talk today, please, before you touch your next patient, ask them, is it okay for me to listen to your heart? Is it okay for me to listen to your lungs? Ask permission to touch your patient, okay? You have no idea how many patients just would appreciate an invitation, okay? Without us just feeling as if we are entitled to lay our hands on someone who actually is a complete stranger, all right? Okay. I know I'm running low on time, so I want to get through some key topics super quick and then leave a couple of minutes for questions. But right here, if you're not familiar with this, this representation here is called the flying gender unicorn. And so it really breaks down the difference between gender and sexuality, which these are two very different things. I won't go into details with this now, but this is something that I go over with all medical students and residents. Alphabet soup, lots of letters, but there's one in particular that has been added as of 2019 census, the number 2, which we don't see very often, but I want to bring this out today, especially with Indigenous Peoples Day being October 11th. 2 represents two-spirit. Okay, and so I was at a GLMA conference, the Gay Lesbian Medical Association conference a few years ago, and a two-spirit individual made it very clear to us that we need to know what this is. Okay, so two-spirit refers to a person who identifies as having both masculine and feminine spirit and is used by some indigenous people to describe their sexual, gender, and or spiritual identity. And so if you are not familiar with two-spiritness, please go to YouTube and type in Two-Spirit Physician Canada. And there's a great 11-minute video, 7 or 11-minute video of a physician who practices trans health care in Canada who identifies as two-spirit. Okay, I can answer questions later about that as well. All right, and so I show this in my adolescent lectures to my pediatric residents in the adolescent rotation. And so I love the picture on the left, and I can't stand the picture on the right. So picture on the left is my son, Bobby, who's the short person in the center. He was 11. This is his 11-year-old well-child visit. And so it was an awesome visit. The person on the left is one of my trainees who is now a MICU fellow at University of Michigan. He was a MedPeds resident at the time. And all the way to the right is our program director, Dr. Eric Ayers, who is MedPeds program director for like 100 years at Wayne State. And so at his visit, the resident, Abraham, wanted to talk about policing with us. And I just wanted to get out of the room to let him talk to my son about adolescent things. But he said, nope, Dr. Riddle, we're going to stay and we're going to have this talk. Okay. On the right, I don't know the context of the photograph. I have to say that. I'm not sure what it is, but it just made my stomach flip when I saw this image, because I see two prepubescent boys, I assume, with their hands on their heads. And I see a police car and I see a light flashing. And with everything going on in this country with policing, it just frustrated me. So racism and policing, this is something that needs to be talked about, especially with our adolescents, but actually with all of our patients, especially our patients who have been historically marginalized, which fits a lot of the patients that I take care of in Detroit, Chicago as well. And so I'm not sure if you all are familiar with the talk, but the AAP put out a version of the talk that is the physician version. And so I bring this up with all of my trainees and students. African-American boys are 21 times more likely to be shot and killed by police than their white counterparts. The same is true, well, not the same statistic, but very, very close for Hispanic, Latino, and Native American boys. It's much higher statistics than for white males or boys. And so, you know, pediatrician's role, this could go to family medicine or just physician's role if you have the opportunity. We just need to acknowledge that it's not fair that youth or just marginalized people in general have to worry about negative interactions with police, okay? Ask if they've had any experiences, and if so, have they shared them with someone? It doesn't have to be an adult, but this is focused on a pediatric talk. Have you shared your experiences? And what you'll find is the majority, especially of Black and Brown males, have had experiences. And my trans identified patients, especially my Black trans women, have had so many negative interactions with police that it's insane. It's insanity. Remind them all their first goal is to get home safely, okay? If nothing else, your goal is to get home safely and to learn about their legal rights, okay? And so this is something that we do with our medical education at Wayne State. We talk about runaways, human trafficking, and a term called throwaways, which some of you may be familiar with. These are children who are told to leave or stay away from the home by another household adult. And the reason we talk about this is because 1 in 20 youth run away annually. Unaccompanied youth have higher rates of trauma, mental illness, substance abuse, pregnancy, STIs. And those who have runaway episodes are victims of abuse and neglect. LGBTQ plus identified youth have higher rates of all of these things, and there's a higher risk of youth going into protective custody, okay? So these are some important topics to teach and go over with your trainees and to learn more about. And then STI testing and prevention. So with my trainees, they are always shocked at some of these things. So ages for STI testing in Michigan, if you are 12, you can get you can get STI testing without your parents' consent. I'm not sure about Illinois and some other states, but in Michigan at age 12, you can go and get HIV testing, chlamydia, all STI testing. You can get contraception. You can get treatment for HIV at age 12, and you can get pre-exposure prophylaxis for HIV, also known as PrEP, at age 12, and it is approved for age 12 and up. And so these services are available. I offer STI testing to all patients, even patients who are partnered, okay? And so a lot of providers will say, oh, they're in a long-term relationship. That means nothing, okay? And you don't know what's going on in long-term relationships, and then how many long-term relationships. We always make assumptions about patients, right? So when I ask sexual history questions, I also ask, how many partners do you have? I'll start off with that. And people are either shocked or very happy, okay? Because I don't make assumptions that people are in monogamous relationships, okay? Even those who are married may not have monogamous relationships. So just not making assumptions about anything in medicine will actually open the door and lower barriers, okay? If appropriate, we test for STIs, especially chlamydia and gonorrhea, in all sites where a person has sexual activity. So I offer triple site testing. So oral pharyngeal, urine, and anal rectal if the person identifies a need, okay? And then the other thing for those who are on their parents' insurance, so that could go up to age 26 with the Affordable Care Act. Those who are on their parents' insurance, they may not want their parents to know they're getting tested for STIs, and that could show up on the explanation of benefits, okay? So if your facility is able to do testing without putting insurance information into the EMR, great. If not, there are some public health clinics and free clinics where you can redirect your patients to get testing and they don't have to use their insurance information. And the same goes for PrEP. I have that same problem. So PrEP, there are 2 medications for PrEP. And so one is for those who are born male identified, and one is for anyone, okay? And so 2 medications are available right now. Truvada is available for anyone and anyone down to age 12, okay? That medication, there are medication insurance coverage programs that work, but a lot of them have to go through your insurance. If you send someone to an agency, such as one of the public health agencies, or a clinic where they have great navigators or people who work with Gilead, which is the pharmaceutical company that provides both medications, you're able to get the medication for those who are on parents' insurance and don't want parents to know, okay? So there's all kinds of little ways to get your patients what they need. PrEP is a once-a-day medication. When taken appropriately, it can cut down your risk of attaining HIV by more than 95%. And so I tell all of my patients about it. The CDC has specific guidelines. They recommend it to people who have more than 2 sexual partners in a year. And they make a huge emphasis on men who have sex with men. But honestly, we have so many female identified patients or women who need PrEP that I give it and offer it to anyone who comes through the door who says they want it. I teach all my patients about it, and I teach my trainees and the medical students and residents to offer it to everyone as well. And like I said, at Corktown, we actually have a prevention team. And so once we have a patient who even asks about PrEP, we'll connect them to the prevention team where they can contact them anytime and learn more, okay? And then the last thing I want to tell you guys about really quickly, because I know we're running really low, vaccines. So why are we talking about vaccines? HPV vaccine, okay? HPV vaccine is so important for everyone. Up until, I think in January this year, it was indicated up until age 45, but I believe there's a new indication that just came out recently for ages above 45. I have to read up on what the age limit is now, but I know that it's higher than 45 now. But up to age 45, all insurances are covering the HPV vaccine. And the reason this is so important is because it's the only vaccine that we have that prevents cancer. And we have such an uptick in oral cancers right now. It's important for everyone to get the HPV vaccine if they have not had it previously. The other reason I stress this with my pediatric residents, med-peds residents, even my internal medicine residents, is because up until age 18 in the state of Michigan, a parent has to make a decision about vaccines. I keep stressing this in the adolescent visits because soon that adolescent will be able to make their own decision about vaccines. And it's so curious how many 18-year-olds will come in and say, my parents didn't want me to get the HPV vaccine, but I'm 18 now. And now I've decided that I want this vaccine for myself. So continue talking about vaccines at all ages. HPV vaccine is an important reason why. And now you all know COVID vaccine and boosters are also another reason why we have to continue to talk about vaccines, okay? So we just scratched the surface of some important topics when it comes to preventive healthcare. Preventive healthcare is important for all patients, but is especially important for our patients who are historically marginalized. And that includes my patients who identify as LGBTQ+, my patients who identify as Black and Brown in the city of Detroit and all over the world. And so it just really was a privilege to talk to you all today. Okay, thank you, Raphael.
Riddle Jones, if anything, I always knew that the one frustrating thing I was thinking about when inviting you was the fact that I could only give you half an hour, because it is, I am always amazed at how much I always learn whenever I get the opportunity to hear you speak. And I think the same, I think I can speak for everybody in saying how lucky we were to have you talk about the width and breadth within this short presentation. So thank you so much for your time. We have a couple of questions in the chat, but I'm going to circle back to those towards the end of this session, if you don't mind.
No,
so that we give our presenters the opportunity to speak. But again, thank you. Thank you so much for presenting.
Thank you.
Okay, so moving right along, just because, again, the nice thing about presenting a track on intersectionality is the width and breadth of topics that will be presented. We'll now get the chance to hear from Mr. Ali Manuel Malik, who is our first oral presenter. He is a third-year medical student at the University of Florida College of Medicine, and he'll be presenting a project titled A Cross-Sectional Analysis of Educational Barriers Impacting Queer, Latino, and Black Medical Students in the United States. Ali, do you have any issues sharing your screen?
No, I'm good, but I'm about to start sharing. Okay, can everyone see my screen?
All good.
Awesome. Okay, so my name is Ali Manuel, and I'm a fourth-year medical student at the University of Florida College of Medicine in Gainesville, Florida. I'm really excited to be here today with you all and continue the dialogue that we started last night. I'm just really excited to talk today. So today I'm going to be discussing my research project titled A Cross-Sectional Analysis of Educational Barriers Affecting Queer, Latinx, and Black Medical Students in the United States. And I have no disclosures to announce today. So to begin this brief talk this morning, I'd like to provide all of you with a bit of background and context for how this project came to fruition and why we really wanted to explore the perceptions of this specific population of students who are straddling two different identities, really. So firstly, it's a widely known fact that many underrepresented medicine students, or URM students, which can be specifically defined as students who are primarily Black, Latinx, or Indigenous descent, face many obstacles during their pursuit of a medical degree. Some of these obstacles have been cited by prior clinicians and researchers as being a lack of mentorship, lack of access to adequate community resources and programming, lack of exposure to medicine, because as we know, many URM students are often the first physicians in their family. So this breadth of data on URM students specifically gets a little bit murky when we start looking at intersecting identities. So there's very few prior studies have specifically assessed the perceptions and experiences of URM students who exist at this intersection, kind of straddling two distinct identities that can, kind of intersect and differ in different ways. So it's important also that I take a moment to define the word queer and why I'm choosing to use the word queer in this context. So queer is defined in many textbooks related to queer theory, but more so for the purpose of this research project can be defined as anyone who is not cisgender or straight. So in this way, queer could be wielded as a very expansive and inclusive term. Also in many academic spaces and research centers, the word queer is almost always used to refer to the populations that we're referring to in terms of like queer theory, like in the academic medical lexicon. we refer to these kind of populations as queer. So for that reason, our research team decided to use the term queer instead of other alternatives. So our objectives for this research project were twofold. We wanted to first identify the barriers that queer URM students face in the shifting COVID-19 pandemic landscape, and then two, establish a framework and recommendations for providing focused support for queer URM medical students, and really just general guidelines for how we can better support these students in their pursuit of a medical degree. So to detail about our methods, we began with a thorough literature review to identify distinct barriers that had previously been identified to impact URM students as an individual group, and then queer students as a distinct and separate group. And for those curious, issues of identity and belonging were more common in queer students than URM students. But again, many of these studies did not make any distinction between queer and non-queer URM students. So in a lot of studies, these populations are often viewed as homogenous. So we then created a 30-item IRB approved survey via the University of Florida Qualtrics system, which is a survey hosting website that we use at UF. Inclusion criteria included all URM medical students at USMD and DO degree granting medical schools. And we surveyed all URM students to have a control group for comparison to better qualify and assess our final study results. The survey was distributed to students via email listservs and multiple online or virtual social media platforms, including Twitter, Instagram, GroupMe, and even Facebook. We primarily contacted student deans to forward the survey to to students who this might be relevant to, and our completion rate was roughly 65%. And again, the definition of queer was defined as anyone who is not straight or cis. So these are very brief excerpts from our 30-item survey that highlight the ethos of the survey in general, which probed into questions about identity, community, sense of belonging, as well as specific and nuanced structural and institutional related questions regarding the presence of diversity, equity, and health inclusion offices or a queer health office. Interestingly, one of our findings that I'll discuss in a second was that many respondents who noted the presence of a DEI office at their institution did not state having a specific office or department at their institution focused on queer health or queer studies beyond a student-run queer health interest group or a queer clinic. So it kind of seemed like these institutions were providing support and resources for queer underserved patients, and importantly so, but there wasn't that same kind of mirroring in terms of support for queer students. It's also important to know that the questions that asked about community were stratified based on URM identity and queer identity. So we would ask questions about feeling excluded or feeling a lack of community in terms of race and ethnicity, and then dually in a second different question based on queer identity. So on this slide, we have a summary of our study results at a macroscopic view. In total, 128 students completed the survey, and we sent out the survey to over 200 students. So like I mentioned, our completion rate was a little over 64, 65%, but we still had enough solid numbers to the point that we could determine significance of our responses based on our research team's statistician. 65 respondents self-identified as queer, and 63 identified it as non-queer. And again, here we define queer identity as being anything that wasn't cis or straight, purposely to keep things as broad as possible to make sure we weren't missing anyone or excluding anyone. A statistically significant majority of queer URM students struggled with imposter syndrome at about 82%, which was much higher than we expected to be honest, but only 57% of non-queer URM students struggled with imposter syndrome. Interestingly, all URM students indicated concerns about fitting in within their medical school community, but feelings of inadequacy and self-doubt were more common in queer students. URM queer students were also slightly more likely to indicate feelings of exclusion and lack of community based on URM or racial or ethnic identity versus queer identity. Reasons for that close but noticeable similarity are likely due to the fact that for many cis students, queerness is something that can, for some students, queerness can be more kept under wraps in professional settings where they may not feel particularly comfortable or safe, but that's not always the case. And that contrasts with many racial and ethnic identities that students often are juggling, because when it comes to a student's visible Blackness, their brownness, right, their accent when they're speaking English, or even their name, those are things that students of color really cannot as easily kind of mask, for lack of a better term, in their day-to-day life, which might explain some of those results. So in conclusion, why is this project important? You know, how does it add to our knowledge as members of the medical community, and what are our next steps? How do we go, where do we go from here? So what we know now after completing this study is that queerness can and does exacerbate issues of self-identity, confidence, and community in Black and Brown students. With that in mind, it's essential that those invested in medical education at all levels of training, especially as it relates to minority student populations, understand this nuance in the context of these intersections. And also an important takeaway from this project is the need for medical schools to tailor counseling and guidance and even pipeline recruitment programming to the nuances of medical student needs and the nuances of identity. So for example, we now know that issues of self-identity and feelings of loneliness may be more common in queer URM students versus their non-queer counterparts. So the need to really mentor these students and provide focused mentorship and guidance is crucial and paramount to the strength of our overall workforce and diaspora. In addition, providing more community resources and programming is also essential to the success of these students. For example, in the survey study, we saw that many students stated that they didn't have any sort of support network or any kind of office for LGBT health or queer health, specifically focused on student guidance and mentorship, which definitely offers an area that we can expand upon and improve for these students and our future physician workforce. So with that, I'd like to conclude my brief talk, and I'm happy to discuss further or answer any questions towards the end of the session. But thank you all so much for listening and engaging in this conversation today.
Thank you so much, Ali. It's always a little bit daunting, sort of like putting these thoughts and concerns to numbers. Obviously, it's concerning, but that's one of the points of importance to basically amplify the problem. I'm kind of wondering, I know that the project is a little bit just limited in terms of how long this has actually been going on, but have you given any thoughts in terms of like, how would you like to see this information applied?
Yeah, so I think this adds to data that we already have on, sorry, I'm not sure if, oh, sorry, I think my audio just kind of backed up a little bit, but I think this adds to data that we already have on student needs and student demographics and kind of what these students need. I think that, like I was kind of highlighting towards the end, this identifies kind of a gap in counseling, student mentorship. I know that I can speak from personal experience and the experiences of my peers that there does seem to be I think these students just need more focused counseling and mentorship and guidance. And this just kind of amplifies that and really adds science to our experiences. So it's nice to have numbers to cite to kind of validate the experiences that you've been having or your peers have been having.
The numbers are the key thing here. So thank you so much for taking the time to put this project together and to explain it to us here.
Yeah, no problem.
Thank you. So to close us out, we're going to shift over to our last oral presenter. I'm now happy to introduce Susana Alverios, who will close us out. She is currently a fourth-year medical student at the University of Illinois Chicago College of Medicine, and a 2021 MOLA MRF scholar. Her project is entitled Latino Male Infertility Management and Referral Practices at Federally Qualified Health Centers. Susana, do you have any issues sharing your screen?
No, I'll go ahead and do that now.
Great, and you're coming through loud and clear.
Awesome. Okay, so let's make sure I can do this right. Okay, and can everyone just see my first slide?
All good?
Okay.
Yes.
And you don't see my notes, right? Awesome.
No.
Awesome. Well, thank you for the introduction. My name is Susana Alverios. I'm a fourth-year medical student at the University of Illinois. And it's my pleasure to talk to you about my MOLA Michael Reese Foundation project on infertility management of Latino males at a federally qualified health center. And I have no disclosure, so let's get into it. Infertility, or the inability to conceive following unprotected sex, is a growing concern among couples in the United States. It's estimated that 8 to 14% of couples are affected by infertility. And though causes of infertility are broad, a female partner's age is considered the single most important factor when predicting a couple's ability to conceive. Female fertility, we know, decreases with age, and therefore in couples with difficulty conceiving, it's recommended that they seek evaluation after 6 months instead of 1 year of trying to conceive if the female partner is greater than 35 years of age. And while increasing female age contributes to a couple's ability to conceive, we also know that there are male factors that affect fertility. And although the male factor is responsible for a couple's inability to conceive nearly 50% of the time, males continue to be understudied. In fact, infertile couples do not undergo male evaluation 18 to 27% of the time, and this rate is also increasing. Male factors include things like abnormal sperm quality and quantity, and things impacting sperm delivery. For example, mechanical problems such as hypospadias and impotence can impact delivery of sperm. Proper hormonal balance is vital to normal spermatogenesis. And one of the most common treatable conditions impacting male infertility is varicocele, or an abnormal dilation of veins that are thought to increase testicular temperature, causing oxidative stress that can damage sperm. There's also literature suggesting that infertility may be a window to overall health. And some studies suggesting that males experiencing infertility may have higher rates of comorbidities such as diabetes, ischemic heart disease, and even alcohol or drug use disorder. And though there's much we do not know, what we know in studies exploring the male experiences is that infertility care in the United States is overwhelmingly associated with affluent, highly educated white males. And studies exploring Black, Indigenous, and Latinx male infertility experiences are rare. The fastest growing ethnic group in the United States, the Latinx population, represents a diverse range of ethnicities and races that impact infertility experiences and care-seeking behavior. But before we can understand, Latino male infertility, it's important to understand the impact of culture. Among Latinos, parenthood is a known expectation, and the stigma of infertility can present a barrier and delay in evaluation. Infertility among Latinx couples has been associated with increased familial and relationship strain and a greater stigma among males and females. Furthermore, language and cultural incongruence coupled with limited resources and a low-income setting has been shown to lead to patient dissatisfaction among Latinx immigrant populations. Differences in approach to infertility treatment between Latino women raised in the United States compared to Latino women who immigrated as adults has demonstrated another potential barrier to infertility care that may also be similar among Latino males. And although studies have analyzed Hispanic, Latino, Latina experiences, they are predominantly focused on female perspectives, leaving much unknown about Latino male infertility experiences. And I'm just going to point you guys to this image here, which is a graph of data presented from the National Survey of Family Growth from 2011 to 2015. And in the blue bars here, you'll see there are differences in by ever having fathered a biological child among men who were born in the United States versus born outside the United States, as well as there are differences in the birth, this ever having a biological child among men who identify as Hispanic compared to non-Hispanic. And what this shows you is just that the rates of childbearing are different among men born in the United States and outside the United States, and also speaks to the variety of experiences that Latino Hispanic men are experiencing in this country. And finally, just a point that's already listed here, but Latino males have been shown to have abnormalities such as azoospermia, which is basically an absence of sperm in the ejaculate, which contributes to conception and ability to have a child. And why federally qualified health centers? So to understand the current medical model of infertility care for low-income Latino males, it's really crucial to identify the practices at safety net clinics that tend to serve underserved populations. And for that reason, I chose to study data from one federally qualified health center, and that's the Miles Square Health Center here in Chicago. The literature has demonstrated that primary care consultations are essential in infertility diagnoses and workup. And one study has even shown that many infertility concerns can be managed before and without referral to urology. And one specific study of 4,200 men presenting to male infertility centers, nearly 20% were referred to that center by primary care physicians. And this is just a map of the Miles Square Health Center, just to give you a sense of the distribution of the centers within the city of Chicago. So that leads me to my objectives. The first one being, how many Latino men attending one federally qualified health center have infertility concerns? And also, among the men presenting for infertility and related concerns, how many complete semen analysis? And also, what percentage are referred to urology for further workup? So to answer these questions, I developed a retrospective chart review of infertility-related visits among Latino men aged 18 to 75 presenting to any of the Chicago-based Mile Square Health Centers during the years 2015 to 2019. Sites included were the main site, Back of the Yard, Cicero, Inglewood, Humboldt Park, and South Shore. The Mile Square Health Center presents a unique system because as part of the University of Illinois Health and Hospital System, patients with urological concerns are theoretically referred directly to the University of Illinois Urology Department. And then this study was approved by the University of Illinois IRB and the Mile Square Research Council. Using a data set created by the Center for Clinical and Translational Science, which I received this week, I will perform the next step of my study, which is to chart review individual records that met the inclusion criteria. And specifically, I'll be looking at things related to the visit, such as the location and the type of provider conducting the visit, such as a resident or attending or advanced nurse practitioner. For the exam component, I'll be specifically interested in if a sexual and or reproductive history is documented among the chart for patients presenting, along with the exam of the male genitals. And finally, I'm extremely interested in learning if patients who are counseled, are counseled on semen analysis, and if they end up completing one. Referral to urology and other specialties such as reproductive endocrinology and labs such as testosterone will also be documented, as they'll provide information on how men presenting for infertility-related concerns are evaluated at FQHCs. And I do have some preliminary results to share with you today. So these are the estimates of the Mile Square Health Center visits from January 1, 2015 to December 31, 2019. So over 100,000 unique medical records were identified for this time period, of which, after selecting for male sex, 41,500 met the criteria. After selecting for age 18 to 75, we have 29,000 records. And then after applying the 90 unique ICD-9 and 10 codes, I have about 400 unique infertility visits. And after doing a little bit of preliminary data analysis, I was actually able to identify 375 visits, of which 18% appear to identify as Hispanic, 61% are single, and the average age is 43. In conclusion, I just want to talk about my next steps and some take-home points. First, the chart review and data analysis will be conducted next. And I suspect for future studies, I'm really interested in looking at doing a survey with family medicine providers at the Mile Square Health Centers in Chicago, just to get a sense of the management of patients and to give better insight into what areas of need there are for providers in terms of education about infertility. And then also another point will be perhaps looking at male infertility care at other federally qualified health centers. As I previously mentioned, I'm looking at one FQHC, and we know that there are many FQHCs in the country, both private and public. And so it'll be interesting to see if what I find here is, applies to other centers in the country. So my takeaway points, semen analysis is vital to infertility assessments. I believe it's a tool that's not performed enough, and I think it's really the first step in assessing a couple's pathway to conception and getting a sense of where a couple needs to go. PCPs, or primary care providers, are partners in fertility care and really do a lot of the preliminary workup for a patient. And finally, infertility experiences among men in the US varies. And while I haven't shown you exactly that they vary from my work yet, I'm really excited to show you that from my study. And I suspect that this study will be one of just many in my work that I look forward to doing in the future. And I just want to say thank you to my amazing team. This definitely takes a village, so I'm really grateful to Ariel Guzman, Dr. Danielle Velez, Dr. Sam Olander, Dr. Pilar Ortega, again, the Mola Michael Reese Foundation, and then the Mile Square Health Centers and University of Illinois Health. And thank you so much. I'll look forward to taking questions.
Looks like we're kind of scratching time, but I commend you for sort of like presenting this to us. And again, good luck with the chart review, because I know it's going to be a decent amount, but like you have some fairly ambitious goals, but it's a very, very important project that not a lot of people think about in terms of male health. So really, really solid work. Yeah, what I would recommend is if people have specific questions for you, for them to message you over the course of the remainder of the conference. And I know there will be the opportunity to chat and have breakout rooms for just general discussion and intermingling towards the end of the session. But before we close out, thank you to all three of our speakers. This is obviously a fairly broad topic that covers a lot of different areas related to intersectionality. And I'm glad that we definitely got width and breadth, not only for the area of Chicago, but also related to topics of area of education and of course, my city of Detroit. So thank you all to the three of you. This was fantastic. If anything, I think all of us just didn't have the opportunity to ask more questions because this was fairly thorough and there was just so much to take in, but thank you so much for your time. I think we're good and we can all transition back to the main room for our selections of our second round of breakout rooms. But thank you all. We also really loved the discussion over the course of the chat. So thank you all for your time.